Okay, good evening, everybody. Welcome to Balosega's third series of our education series, How to Ace Your Interview. My name is Sir Bobby Sega, and in the building we have my fellow partner, Sheye Balogun, who is a wonderful consultant in West Hertfordshire Teaching Hospital, NHS Trust. Basically, that's where they make the money. So if you need loan, sorry, when you need loan, just go there. Don't meet me, just meet him. Uh-huh. We also have a wonderful friend and brother, Andrew Alalade, who is the main panelist today. And always supporting us is Ejiro Eyaru, a wonderful GP in the UK as well. So thank you all for coming. Um, this is the first time we're using actually Microsoft Teams, and we want to apologize for that delay. We had to make sure that everything was on point to make sure that we get a wonderful time. Now, without wasting time at all, we would like to invite Andrew Alalade to share and hit the nail on the head, as we always say. So over to you, Andrew.
Yeah, thank you. Thank you very much.
You are most welcome.
Thanks for the
just before you go, if anyone cannot hear him at all, put it in the chat. If you have questions, which we believe you have questions, just put it in the chat. We'll be able to read that out afterwards. Thank you very much. I'll just stay mute and allow Andrew to just take charge now. Yeah.
Okay, cool. Oh, some people are still waiting, but I think you'll be able to
bring the
yeah. Okay. So I will just share my screen. Yeah, can you see that?
Yes.
Okay, perfect. Yes, so how to ace your job interview. This is a kind of clear-cut topic. And the first thing I asked myself when I got the invitation to give this was, why am I the one being asked to give this presentation? I would personally think in terms of job interviews, I've probably done so many within the NHS at different levels and different, different hospitals all over the country. I am a consultant neurosurgeon. I graduated from UCH in Ibadan in Nigeria, 2004. Did, house job in UCH, did some part of NYSC as well, and then came up when they only just introduced the foundation program. So I think I was one of the first people who did joined the first foundation program around that kind 2005, 2006 period in Scotland. And I did that because I wanted to do neurosurgery. So I went to Scotland for that, for a foundation program that had neurosurgery. I did a couple of SHO jobs in Glasgow and Leeds, and got into neurosurgical training in 2010. There were 9 jobs in the country at the time, so I got into ST3, finished my neurosurgical training in 2016, and got my CCT that year, September 2016, and then I did a couple of fellowships. Went to Australia, went to New York as well. And at the moment, I work as a consultant neurosurgeon in skull base and vascular and Royal Preston Hospital. So I'm going to be giving this presentation based on, kind of dual facets, as someone who's interviewed a lot of people and as someone who's sat on the other side as well as an interviewee. Now, the first way of looking at this is a bit of a funny slide, and to the people who understand, these are the world's largest employers. So top left, you've got the United States of America Department of Defense. They've got about, I think, 2.9 million people in their employment. You've got the People's Liberation Army of China. Next to it, you've got Amazon. Amazon has joined that list very recently. And then you've got the Ministry of Defense for Russia, and the India's Revolutionary Army. And then you've got the almighty NHS. So the best way of looking at the reason why I put this, the NHS has got, I think, 1.7 million people in employment, is to look at it that it's a bit of a fight to a finish for any job you're getting. And the way I look at it is when you go for an interview, you can easily be replaced. So you have to go for that interview with your best foot forward. If you don't show up, they would easily get someone else to do the very same job that they were asking you to do. So when you go for an interview, it's always about putting your best foot forward, and that's the whole point of this slide. As medical doctors, I think we get carried away with this idea of IQ. That's the one thing exams test, about who's got better IQ than the other person. But most of the interviews are not really to test IQs. They're really to test how good you are emotionally, kind of EQ quotient, SQ social quotient, and you should be able to demonstrate all three things in your interview. Appear confident, that's all about your EQ. Know how to give safe answers, safe responses. Never give answers that would make you appear as someone who's going to kill a patient. And the SQ is you should be able to read the room, modulate, you know, when you smile, you know when to smile. Sometimes you could even crack a joke with your examiners or with your interviewees. And it's all about having a good mixture of those three. We all know that for you to get to that stage, you've passed your exams, you've got the IQ. So it's all about how you modulate the other ones. I put this slide up because this is Reggie and Bolly. They were a funny duo that came on X Factor about, I think it was 2015. And they went all the way to the finals. I think they were runners up. And when they first started, everybody looked at them as, you know, more this Ghanaian duo. They're not even sure of what they're on about. But they just had the X factor about them. They were able to get the crowd on their feet. You know, I look back at their music now and I'm like, they look like rubbish music. But, you know, they were able to sell something to the crowd. And that's the same thing. So really, for most interviews, for most exams, we're literally like Reggie and Bolly. We just have to show something that is special about us. We're advertising ourselves to get the job. I always like to compartmentalize things. So it's, you know, I look at things like in three segments for an interview. There's the before the interview aspect, there's the during the interview aspect, and the after the interview. It's not just the interview, and you need to always remember that. How do you do things before the interview? Make sure you read the job description, make sure you're a good fit. Sometimes you might not even be a good fit, but even if you believe that in the next 3 months, 4 months, you would be a proper fit for that. Sometimes you could still apply for that job as well. And you see most consultant jobs, for example, using a consultant job, for example, they'll tell you that you should be within 6 months of getting your CCT. So it means that they believe that, you know, you're on track to getting to the point where you're going to fulfill that job description. So it's not every time you look at the job description and think, oh, have I got this, have I got that? If you think you're on track to get in there, then why not, you know, go ahead and do that. Visit the department if you can. I know it's difficult, but if you can visit a department, try to. I definitely have been a beneficiary of that. I visited the department several years ago when I was a registrar of rotation, and just that one day being spent in the department asking questions, meeting everybody, was pretty much what the interviewers spent the first 5 minutes of my interview discussing about how I impressed them when I came around to the department, only because I decided 2-3 weeks before to come in and meet everybody. You should know the trust's values, and it's a bit like name dropping in a conversation. If you know the trust values, even if you don't get asked the question, you should find a way of dropping it in conversation. Know what your department's main challenges are, the department you're trying to to join. And oh, something's gone wrong with this, with the Google one covering up. The part underneath that Google thing is who's on your interview panel. So when you look at the your panel of interviewers, try and check up who the panelists are. Know what they like, read up about them, know what works they're popular for, what they've done, what papers they've done, all of that, what projects they're pushing, and find a way of aligning yourself with that. And on a lighter note, I know people who've got jobs. I know, the few Indian colleagues I know who got jobs only because they were good cricket players and did a lot of, playing of cricket. And obviously the professor in the department was able to appoint them because he also needed people who were going to play cricket with him over the weekends. So sometimes these things matter. Google is your friend. Google up the influential people in the unit and, use it in the conversation. Now, I'm spending time to talk about the non-academic part of acing your interviews because I believe that the academic part is something that I can't teach anybody on, and I'm a surgeon. So there are people who are probably in medicine and A&E and GP. So I'm trying to touch on other things apart from the academics. You should take time to build up your portfolio. It's always about giving a very good impression. So have, a very good portfolio. Even if there's not much in there, at least partition the folder that you're gonna take in. So partition the folder, divide it into different segments, have one part that's maybe from your university time, have one part that is on academic qualifications, have one part that is on references, compliments, one part that is on, management training, stuff like that. So make sure it's well partitioned and, have it pretty much be battle ready for the day of the interview. Your references do matter. And if you have a referee who you're not really sure it's 50-50, then it might be worth not adding that referee to your list of references. And I've definitely been in that spot before where even, I think my very first job, when I was in my first job in the UK, one of the referees was someone who did not really like me, and I got a hold of his reference for me because he sent it to me. And I it was a good thing that I had the opportunity of changing the referees. So I had to even write to one of my tutors back in Nigeria to fill in as a referee. So it is better to have a reference that, blows your trumpet, talks about you in glowing terms, than have someone that is 50-50. I think that's one thing you definitely have to take on board from here. For the day of the interview, you definitely have to arrive early, way before the time. Clarify the job description. As I said, prepare for multiple questions, and there are a lot of them on the internet. And I'll talk about one or two in a bit. You've got to be confident, you've got to dress appropriately. I definitely know someone who wasn't given a job because he wasn't dressed appropriately. And this also goes for virtual interviews as well. Virtual interviews, which have become really popular now because of COVID, have shown that sometimes you don't necessarily have to be there face to face. But even then, try and make sure, even if it's from your waist up, try and make sure you dress appropriately. Go through all your documents. You don't want to arrive at the interview venue and not have the appropriate documents. And regardless of what subspecialty or specialty, make sure that you're up to date with policies and guidelines, the ones that are most relevant to the work you are going to be doing in that department. It's all about selling yourself. It's all about dropping the language, and you should have a low threshold of showing off your knowledge of the NHS. And for me, I think that's key for many of the jobs. It's how well you show that you are someone who understands the internal workings of the NHS. That tends to be the key. Yeah, the different mnemonics to remember how to tell how to talk about yourself. If there's one from a large sample size of all the questions that come up in interviews, the one question that everybody believes is a constant is the tell me about yourself question. So tell me about yourself or tell me about your CV. That is a question that 9 out of 10 times is a constant in any interview. So personally, when I bless you, personally for my mentees and people who are trained for their interviews, I usually get them to record themselves talking about this. So even if it's a 30-second recording, record yourself and put in the camp mnemonic. So break it down into the 4 segments. Clinical, you could either start from now and work your way back in retrospect, or you start from the very beginning from med school and work your way up to where you are. It depends on how you want to play it. You talk about your academic qualifications, talk about management, what you've done in different groups, and sometimes we tend to underplay our achievements, you know, especially for people who maybe have not worked in the NHS. You've gone for M&M meetings, you've presented, but because they're not known as maybe journal clubs or regional or international meetings, we wipe them out of our CV, and that's not really right. You have to include them, do a bit of lateral thinking out of the box, and then you can add a personal touch to it and talk about, yourself, how many siblings you've got, what other skills have you got with skills that are easily translatable into the job you're going to be doing when you're successful from the interview. Now, I put this, and this is something I've used very effectively over the last 12 years or so. Now, it first started in Canada, where the Canada medical framework, they came up with the fact that the 21st century physician is not just a physician. So you have other skills than just being a medical expert. And those skills are things like being a communicator, a collaborator, a leader, a health advocate, and you can see that on the slide. Now, the GMC kind of literally copied that. And what they've done is they now have, it's very similar to what the Canada's CanMeds framework, and it's called the 4 domains of the good medical practice. And you have to sell yourself in every interview that you are an ambassador of those 4 domains. So you look at the fact that you are keen on CPDs, developing and maintaining your professional performance. You are a safe doctor and you understand the impact of quality impact assessments or significant event analysis. You are a good communicator. You work well with people, not just in your team, but the extended team and the allied health professionals, and you're able to maintain trust. So you detect things, you feedback, you deal with complaints, and you reflect accordingly. And every interview, you have to find a way of showing your interviewers that you have these attributes, these 4 attributes, 4 domains pretty much. Now, buzzwords. These are a couple of buzzwords that you have to sneak in when you're talking, and practice them a lot of times. So things like patient safety is definitely top priority. Team working, communication, reflecting, escalating when you know it's beyond you. Feedback, you're dealing with feedback, whether positive or negative. And whenever you mention the word audit, always, it's like 5 and 6, husband and wife. Always make sure you also use the phrase close the loop. it shows that you understand, you're proactive, and you know what the sequential steps are. So it's not enough to just say you're going to audit something, because audits are kind of inevitable. They're part of every interview in some way or form. You always have to say you're going to close the loop. You want to improve outcomes, you're safe, you want to be proactive, responsive, you want to demonstrate leadership skills, and you want to be very good, well-versed in conflict management. Now, whether it's medical, whether it's anesthetic, whether it's surgical, A, B, C, D should always be at the back of your mind for clinical questions. So you want to make sure that, according to the resuscitation plan, you maintain airway and C-spine control, breathing, circulation, disability, and this covers pretty much every clinical scenario that you're given. So remember this, and don't just do what most people do, where they just jump straight into dealing with the clinical scenario. Many times, and you have to be very skilled at how you bring it up, because if you do it and you go too long on the ABCD, then everybody knows you don't really know what you're doing. So it's just, a quick mention, and then you go into the management. But most things UK, ABCD is usually your starting template. Now, why is clinical governance so important? Clinical governance, it's funny, I was looking at, Baloni is someone I've known for many years, and he's an anesthetist. And this story makes me very wary of anesthetists, because prior to 1995, there was a high mortality rate in pediatric surgery in Bristol. And there was a chap, I think his name was Stephen Boslin. He was the one who whistle blew. He was an anesthetist in the department, and the cardiac surgeons were pretty much, they couldn't be touched by anybody. So a lot of babies were dying, but nobody could do anything about it. So it was this anesthetist who literally had the boldness, the balls to come out and talk against it. And when the government, the media heard about it, it caused a lot of problems. So much that the new Labour government then announced that they were going to be implementing something called clinical governance. And this is how many years ago now? This is like nearly 30 years ago, but it has come to stay, and it's very important. There's 7 pillars of clinical governance. You can see 6 of them there. Information management is the one that is missing, but you have to find a way to be able to talk about the 7 pillars. So education and training, audit, clinical effectiveness, which means that you want to get the best for your patients. Research of development, you have to show that you're willing to do that. Openness, which means that you're going to be honest. And then risk management. So those 7 pillars, you have to be able to kind of whiz through them, no matter what interview. And when people literally hear you talk about this, they know that you're being safe. Now it's sad because this anesthetist who whistle blew was not able to get a job in the UK again after whistleblowing. I think he's in Australia or something now, but that's just by the side. There are a few other things that you might need to mention and there are many of them, but these are the kind of examples that people tend to look for to show that this person understands what's going on in the NHS. So sometime about 2009-8, there was the implementation of the European Working Time Directive. So before then in the NHS, you could work for as long as you liked, and you were paid for it as well. But then the European Working Time Directive cut everything down, so maximum kind of 48 hours. So the way the government, they came up with this thing in terms of providing a good service for patients was to provide something called a consultant-led service. So that's really what the tempo report means. And if you are coming there, you should be able to talk about this. Either you're working with your consultant or you're escalating things to your consultant, or even if you're coming as a consultant for an interview, you should be able to throw these terms. Duty of candor means if anything goes wrong in a procedure, a statutory report has to be filled where you talk to the patient about it. You have a family meeting, it is documented. So you have to document it where you talked about either the adverse effect or the complication or whatever treatment was given to the patient. You have to mention that Montgomery versus Lanarkshire. So that picture is Nadine Montgomery, and she sued the Lanarkshire Health Board. I think she got about £5 million, and that was because she was a short lady, she was diabetic, and they told her about the risks of labor. This was in O&G, of the delivery, but they didn't. Maybe they should have given her the option of a cesarean section. They didn't mention that the child could have shoulder dystocia or maybe even consequently cerebral palsy, and they went ahead with the treatment. So what the Montgomery's ruling has said is, no matter what, if you're going to consent a patient, you've got to mention every possible complication, no matter what, even if it's less than 2%, less than 1%, you have to mention everything to the patient. Mental Capacity Act, before you carry out a treatment, that's from 2005. You've got to show that the patient understands, is able to retain the information, can use it in decision making, and can communicate it back to you. And that's literally what the Mental Capacity Act means. And then DATEX, where you have to be able to fill in anything that you feel is, well, has to be dealt with, or is more of, something is wrong with the system. It's a kind of root cause analysis. You fill it in, and you have to remember when you're talking about DATEX that patient's details are anonymized. That's the key part of DATEX. Now, what happens with all the DATEX is it actually gets pulled nationally. So there's a national service line reporting. So all the information is actually weighed and considered on a national level. And then they see how, pretty much plot the graphs and see which ones are more than which, and see how things are improving or how things are getting worse. So you need to be able to drop these terms in whatever interviews that you're doing. If you get given a question where you're going to be dealing with a difficult situation, then you got to use the SPICE mnemonic. So you talk about gathering all the information, seeking information. You want to be sure that the patient is safe. Then you find a way of portraying that you're showing initiative, escalated. And so you should be aware of the hierarchy in the department. And this is a place where you can bring that in if you're aware of the hierarchy. So you want to know who, if you can get the consultant on call, fine. If you can get the registrar, fine. If you can't get the registrar, another registrar. If you can't get the consultant on call, another consultant. If you can't get that person, then maybe the clinical director. If you can't get that person, then the medical director or divisional director. You want to be able to escalate it, and you want to be able to get support for whoever is involved in the difficult situation. And one way of covering your back for a difficult situation question is to also say, as a sign off at the end, that I would also be referring to the trust policy on that issue, because most things that are that have to do with ethics or difficult situations, most trusts will have some policy for it, but most people do not know because they're not aware, because nobody tells them. But that's why we've got this kind of discussion today, to make you aware as much as possible. If you're told to give an example of when you did something, either when you led a group or when you carried out a project or when you made a mistake or whatever, then you can use the bearer mnemonic, where you give a background, kind of a context of why that matters to you, the action you took, the reasoning for why, and then with the reasoning you can hinge it on something NHS, either Tempo report or Montgomery, find something to back it up, and then talk about your end result and talk about your reflection. Okay, we're all aware about the Bawa-Gaba case. And one of the things that highlighted from that is how big a deal reflection can be. So always talk about your reflection and how you're going to be going on forward from whatever you've done. And it doesn't matter if it's positive or negative, but make sure you give that reflection. Now, wrapping up here, at the end of your interview, they might say, oh, have you got any questions for us? And usually, I would say it should be one of two. It should either be something specific that you have learned from the visit to the department or from your knowledge of the department, something to make the interviewers know that, yes, this man or woman has done some good research about our department, about the team he or she is going to be working with. Or you could say, I've not got any questions because I have met with Mr. A, Mrs. B, Mrs. C, and Dr. D, and they had already answered the questions I had in mind already. So that also shows a kind of proactive attitude that, well, you'd already preempted the interview panel, you'd gone up with the issues at hand, and you'd got it all sorted. And that's where I'm going to be wrapping up, and happy to take any questions at the moment.
Andrew, thank you so very much for that wonderful, very concise, professional delivery. Thank you so very much. I was apt. I was calm, cool, calm, and collected, to be honest. So thank you so very much. What we normally do is to encourage everyone to, if you have questions, which we believe some people will do, is to drop it in the chats at the moment, and we will take up everything together wholesomely. Before I call on Chair to say a few things, first is if you missed out from the beginning on this presentation, you could go to our YouTube channel, just type in Balosega, you look for it, you find it there. It will be posted shortly afterwards. And also previous ones we've done. Remember, we've done two major ones. This is a third educational series we're having. So if you want to watch previous one and other short snippet videos as well, you just go to our YouTube channel. Now, don't just go there, please, and just watch it and go. Please subscribe. So when we post anything on our YouTube channel, you'll be the first to get the notification. So just go there to watch the old videos we've added on our YouTube channel. Thank you very much. I quickly call on my partner, Ejiro Balogun, to share and also do a very short presentation as well. So over to you, Ejiro. Thank you.
Hello, can everybody hear me?
You're quite blurry, though. You're quite blurry.
Very blurry?
Mm.
Okay, can you see my slide at all?
Not at the moment.
Okay, just...
Okay, whilst you're trying to do that, Ejiro,
yeah.
Maybe I'll call on Ejiro to quickly jump in so that we'll clarify that, because we don't want people to wait for too long. So I know it can be network. Network can be very funny, to be honest. That's what happened at the beginning. So Ejiro, you could quickly jump in. Just to let you know, Ejiro is a panelist. He took charge of the second educational series we had about 3 months ago or 4 months ago. And he's here today to support us as always and as usual. Thank you very much, Ejiro.
All right. Thanks, everybody. And thanks, Dr. Alalade. That was a very lovely presentation. Incidentally, many of the things I researched about this overlaps with some things that you said, but I'm not, I mean, it's so that I don't repeat things you've said, just to highlight some areas which you've actually touched on. I don't have a slide per se, but I've got a PowerPoint presentation or sort of something to just give me a guide. I think some things that we need to look at. We touched on introducing yourself essentially. Now, when someone asks you about introducing yourself, it's not an opportunity to go into the nitty-gritty of your CV. It's just basically to highlight main things about yourself, things about your skills that you have, your experience, and those things that actually make you a good fit for the job which you're applying for. Yeah, very, very important. Now, other issues you want to look at is this could come up. Why are you actually applying for this job? Why do you want this job? Now, in trying to answer those questions, you need to be smart about it. And one way, like Dr. Alalade said, was you need to familiarize yourself with the trust values, the person specification. What are you going to add to that job environment, and what are you going to benefit from the job environment? So these are things you can actually integrate in your answers. Now, take note that in answering questions, you don't necessarily have to rush through. You don't need to have to jump in and just answer immediately. Sometimes, even if it takes 1 or 2 seconds for you to reflect on what you should do, or how we should approach any question you are asked, it's actually worth doing that before you jump in. Now, for the issues of clinical scenarios, one overarching objective is that you must always demonstrate that you are a safe doctor. It doesn't matter how much experience or skills that you have. If you're not a safe doctor, then you will not necessarily be a good fit for that job, no matter what credentials you bring to the table. So basically, there are different scenarios that people would get depending on the specialty, but most of the scenarios I have come to realize are anything that if you're a junior doctor, for instance, if you're applying for an SHO position, which many people will be doing, you are looking at things like emergency. What sort of emergencies would you manage? How would you manage them? Now, even if it means that you have to jot down the question when you are asked, please do. So I'm just talking about practical things, because you may forget a detail that has been given in the question. If you have a jotter, if you carry a piece of paper, if it's a virtual interview or in-person interview, just make sure you write some things to just give you what things you touch on, and also where you'll answer. We've talked about the ABCD approach, very important. And I will say this, sometimes they be to impress your interviewer. Some people say things that are outlandish, things that would not necessarily be practical in managing that scenario. Please do not do that, because when you start mentioning things that don't make sense, some highfalutin stuff, you just show that you don't have the presence of mind to manage things in a practical setting. And yes, one other thing when you are discussing clinical scenarios is always make sure, I think we touched on this, think about escalation plans. How would I escalate if I've come to a point where what I'm managing is beyond me? So usually for an SHO, you escalate to your registrar. Now, as a registrar, you would have to discuss things like, okay, how do you talk with other specialties? How do you liaise with them to actually bring out the best outcome for patients? So, and things like DNARs, how you involve critical care, if that is the direction that your case is going. And sometimes one thing you may ask yourself, or some people may be disappointed because you're not seeing you were expecting, I need specific questions to prepare for. Now, nobody's going to give you specific questions. Now, one way you can actually look for specific questions is Oxford handbooks are a very good resource when you look at common cases that are managed in your specialty. So if, for instance, you're a surgical person, you go into your Oxford handbook and look at, okay, what are the common cases or common emergencies that are managed here? Not necessarily chronic cases, but those things that are common where they want you to actually bring your competence to bear. And also ensure that your answers are always structured. Don't just go, let your answers be such that you can follow your train of thought, your line of thought, and your logic, essentially, to actually answering those questions. And like was mentioned earlier, nice guidance is very important. If you look at the Oxford handbook and looking at always managing those scenarios, you find out that usually they always defer to nice guidelines, because they form the bedrock of managing patients when it comes to clinical practice in the UK. Now, also, you can actually mention that there could be trust guidelines, because the trust guidelines sometimes are locally adapted guidelines based on the nice guidelines, but they're just little modifications here and there, and those actually form the basis by which most trusts work. I've never encountered a trust where they don't have their own local guidelines. And Yeah, very, very important. Now, there are sometimes when you are asked approach-based questions, how would you approach it? For instance, a patient that is breathless, you need to think stepwise. That's where the ABCDE still comes in. And like I said before, escalation. Now, other parts of the interviews will involve asking you things about leadership and ethics, so ethical scenarios and leadership scenarios. So things that they will usually be looking at is how can you prioritize as a doctor? If you have a lot of things to do, which comes first? Now, usually we know that anything that is that will alter, that's life-threatening for a patient will definitely come first, and other tasks will actually be prioritized lower. How you prioritize, how you multitask. When there are many things to do, how do you actually make sure you multitask and do so in a safe manner? Now, you need to familiarize yourself when it comes to issues of ethics. You need to familiarize yourself with several issues. Duty of candor. When you have made a mistake, how do you actually approach this mistake? And how do you speak to the patient and things like that? Duty of candor. Things that have to do with consent, like you heard earlier. When it comes to consent, you need to give the patient all the information, because remember, it has to be informed consent. So they need to know the pros and cons of whatever procedure or activity that's going to be done. Yeah, so consent is very important. Duty of candor. Also things about confidentiality, when to know when to share information and when not to share information. Then also looking at things that border patient autonomy, because there are scenarios where a patient will actually make a decision. You may feel that the patient decision is a bad decision in terms of outcome, but remember that the patient has autonomy which cannot be broken. And when we have ascertained that their mental capacity is intact, their decision, they are still entitled to their decision. Now, things like problem-solving skills will actually be brought to bear, which they don't necessarily follow any standard. They just want to see how you can think on your feet. So problem-solving skills, how you manage teams, if you are working in a more senior role, how you delegate tasks to ensure that things are done efficiently, and also things that bother about managing stress. Yeah, stress at home, stress at work, and organization and planning. Those are things that can actually be asked about. I think Dr. Alalade talked about audits basically. Now, I know that most people that are sitting for this discourse this night, you may not have an audit where you're coming from. I never did an audit until I came to the UK for a clinical attachment. But it doesn't matter. If you've not done an audit, so long as you understand the principles of an audit, you will be fine. You can tell them I've not done an audit, but what I understand from my research is that audits do X, Y, Z, and these are things I will actually have to do in order to, do an audit. And closing the loop is very important, because when we try and audit a process, we need to make sure, or we need to find out if there's been a change in any, if we implement any actions at all. And I think the last part I'm going to touch on is the issue of, do you have any questions for us? Now, please don't start asking about your salary. That's not a good avenue to say, okay, that is a no, because it means that your priorities are just off. Your priorities are skewed. You're not there already. Okay. Now, things you can ask about. These are just some practical questions you can ask about. Ask about research if that is what if that is what your interest is in. Ask about any training opportunities. If, for instance, you're interested in a CSER, if they support a CSER, ask them about study budgets. This is where you can talk about money. Do you have people that have this, that take on this role? Does the department have a study budget for them? And also ask about things. You can ask about things about shadowing. Do I get a period of shadowing? How much support do I get how much support will I get in this role? And things like the work environment. You can ask about, now, if you don't know, you've tried your best to find out about the challenges that the department is facing. You can ask them, if you don't know, what are the biggest challenges facing the department, and what would you expect anyone taking this role to actually contribute to make sure that those challenges are better dealt with. Then, if you don't know, this is one place you can ask, what's a typical day like? Because for all you know, you are getting a job where you'll be expected to work very long hours, very odd rotas. People have rejected jobs because of rotas. So I think that is one place you can ask. When they ask you, what questions do you have for us? Or what's a typical day like? What would I be expected to do? When do I resume? When do I close? And all that. And at the end of your interview, one other thing you can ask them is, what's the next step? What comes next after this? Now, if they're obliged, if they're inclined to do so, they will actually ask. They'll tell you, okay, next step is we'll be in contact with you, or there's another stage or whatever. But these are the these are just some of the specific things you can look at when preparing for an interview. And remember, the word is this: prepare. You cannot attend an interview unprepared. If you do, they will pick it up very, very quickly. And remember that your CV has put you through the door, but your interview, like as we said earlier, is your time to shine. That's all from me at this point.
Thank you so very much, Ejiro. Appreciate that. Really, really good nuggets there. There's something you said, just rounding up, prepare. And if you don't prepare, they will pick it up. Very true. I mean, well, I'm not a doctor, but I've had a lot of interviews as well. I'm a business analyst background and everything. And when I used to go for interviews, the ones I didn't prepare, I knew. I just knew. So it's very, very vital because as a professional, you have professionals interviewing you. If you blab, muffle and blabble and blab and blab and blab, they just know that you're just wasting time, and they just nod and just say it's right, it's okay, it's okay. But it's always very good to prepare. So quickly, I'll call on Share Balogun to, his slides is showing now, as you can see, and I'll call him to just take over for a couple of minutes and deliver his own lines. Thank you very much, Share. Are you there?
Yeah, thank you, Bobby. Can you hear me clearly?
Yep.
All right, good. Thank you to Felicia and Ejiro. After such a beautiful presentation from both of you, you've made my work very easy. I'm left with less than 10% of what to say. So I'm one of the co-panelists, and I am one of the founding partners of Balogun. So basically, we've had a few educational courses in the past. We've done do's and don'ts of GMC registration and search for the NHS job with same Dr. Ejiro Eyaru, who's always been helpful. If you're interested in watching those ones, because you still need to do your GMC registration or you need some information about NHS job, you can go to our YouTube channel, where we usually will post after such a meeting so that people can watch afterwards. And if you have any question afterwards, maybe your questions, you didn't get to ask your question, or you watch it on YouTube and you still want to ask some questions, you can send your message, your questions to our email, balosega@yahoo.com. So Balosega, this program is coming to you courtesy Balosega Accommodation. And we have a couple of accommodations in Manchester, started with PLAB 2 candidates, but we've had more than PLAB 2. We've had USMLE people coming over. We've had masters, we've had obstetrician, GPs, people who need time to study and they just want a place to stay. We are open to them. And some have actually come for PLAB 2. They've returned to work and they stayed with us, or some come on locum and they stay with us. So everybody's welcome. Send us an email and we would clarify what you want, what we have, and we tend to meet people's needs. We want to make Balosega something more than an accommodation. Hence why there's mentoring ongoing for people who have stayed with us. You have the connection with us. We know you, you know Bobby, you know myself. You can always send us an email. We can guide you through. We've been in this UK I've been in this UK almost 10 years now. We do CV review for our guests. NHS job search, some people are like, which one should I go for? This is my experience. You're like, oh, don't go for this because this will be a lot of responsibility on you. Start from this. I always say to people, starting from outside, coming from outside, go for a non-training post and learn the NHS way before diving into, if you dive into training posts, it's good, but then you cannot tell them, I'm just coming from abroad. That's why it's get on the ground running. That's the case. And we do a lot of educational courses and interview practices. These interview practices, myself, Victoria, and a few other people join us for this. I've seen candidates improve exponentially. And I always say to them, when I'm fixed to take anybody on interview practice, I say to them, my first question will be, tell me about yourself. So go and do that, recite it, and come, let's do it tomorrow. And again, even though you've told them that the first question is, tell me about yourself and just rattle to me your CV, a lot of us will still struggle with it. So I said, don't worry, it's all the same. You're not the first person. Just do it again and again. By the time we do the first one with the feedback, second time, they are like, wow, this guy blew my mind. They say, that was what you taught me. And then they just text you a few, maybe a week or two, I got the job. Or some of them will say, oh, I didn't get the job. I said, don't worry. Send an email to ask them about a feedback. And from the feedback, we work on it. And they do very well. And like I said earlier, we also take non-PLAB doctors. So the NHS job interview usually would have about 3 or 4. There will be 2 consultants usually for your level at that interview. There will be the lead employer, and he will bring one of his colleagues in. And there will be an HR person who takes care of other things and will be doing the email later. And other people can actually join. At the end of the interview, a few people, I'll say less than 5%, will be offered the job. Maybe you're just that good. Just like this guy is the best. Everybody agrees, let's tell him that. Or you're the only one who's turned up. Whatever the case is, you've got a job. Results for exceptional candidates will be reviewed. But then some people will be told, we'll get back to you. It's either you're not the best or they still want to discuss with themselves. Whatever happens, just go home. You've done your best. Just wait for the result. Sometimes they offer the best person and the best candidate has got another job. So he turns it down and then they say, okay, this is the second guy on that day. Let's offer him. So don't lose hope. Some will say, oh, they have not called me in 24 hours. It doesn't matter. There's no time limit to it. Usual question on that day, Felicia is touched on it, Ejiro is touched on it. I'll go briefly on this. There will be a management question. There will be communication and teamwork. Whatever they ask you, just make sure you put the buzzword Felicia's mentioned earlier, your experience and your skills. It's a clinical question. The other presenters have talked about it, and the best way to get it precise, succinct, and straight to the point is to have your own Oxford handbook. If you're going for emergency medicine, you must have the Oxford handbook of emergency medicine. So that anything you just like, bam, 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 these are the things. They'll ask you questions about difficult colleagues. They just want to see that you are safe. There's no right or wrong answer. This guy is not safe and is working with me, I would escalate to my boss. Let the boss deal with the rest. A few of my co-presenters have mentioned different things, but what I find the best question when they say any question for us is, I would usually tell them, what advice would you give me as a new doctor starting this role in the first 2 months? So I'm telling them that I'm getting the job. That's it. Never talk about salary during an interview. So Felicia's mentioned this, your job specification and person specification, read them very well. Those are the things you'll be chipping in as they ask you a question. Know your CV very well. Never be late. Relax and be calm. Always smile because they want to see, is this guy going to be someone I want to work with? Is this guy just going to be frowning every day? Dress smartly, be professional, comport yourself. And always remember, this helped me very much when I was doing an interview for consultant position. A senior colleague told me that if you take an interview like an exam, you won't do well. But if you take it as a discussion, you do better. And that changed my perception. I get to an interview, I'm not stressed, I'm smiling, I'm cracking a joke, I'm laughing too. Always show you have good communication and empathy because that's the most important thing. Knowledge is no longer the best for any doctor. To do well in interview, you have to practice and practice and practice. You have to talk and talk, and you can always email us to fix a practice time for somebody to just see the job specification and talk to you about it, interview you. Always remember to ask for help. If you don't know the answer, you're like, oh, I cannot remember this at this time. You're not telling them that you don't know it. You're saying, I cannot remember the details at this time, but I will do and get back to you. Don't start confabulating. Don't bring things out that are not real. If you're unsuccessful, it's not the end of the world. Email them. Thank you for the opportunity for having me. Can I know where things went wrong? Most of them will say, you did well, but you were not the best on that day. And then you say, okay, fine. Some will say, oh, you did so well, but at the clinical stage, you messed it up. There was a candidate who got that feedback and we just worked on his clinical. So you must get that right and relax. Everybody will get a job. Thank you very much.
Thank you so much. Thank you very much for that very brief one. So we go straight to the questions now. And Andrew, get ready. Bombarded you with questions. Right now, you're on your own.
Okay, so
I will try and read out the questions to, you know, so that we don't waste time in that area. Let me just start from the very top of the question board. Just spare me one moment, please. Okay. Can you write the YouTube? Okay, yeah, the YouTube chat. Okay, yeah, it's been written. Balusega. Just check for Balusega. That's our YouTube channel, and you'll see all the old videos. So this one, the next one is from Chisom. Thank you for the presentation, sir. Yeah, my question. So more than one question. I'll take it one after the other. How important are the essential criteria for the desirable criteria that are attached to job adverts? Some people say you should still apply regardlessly, but is it worth applying for something you don't meet or some of the essential criteria? And if you meet the essential or you don't meet some of the desirable, what are your chances? Do you understand the question?
Yeah.
Good. All right.
So Chisom's question, that's it's these things they're not like totally clear cut. So if, for example, if I'm putting out a job, I would say essential criteria, because I want 90% or most people who are applying for that job to have the essential criteria. Then sometimes the desirable criteria will be, if, for example, you want a few people to stand out, you know that not everybody might have those qualities, but you're hoping that maybe that will help you to differentiate between the people applying. Now, nowadays, you know, these things have gone in cycles. There was a time many years ago where when you put an advert out, you might just get a few, and then you're just praying for people to turn up at the interviews. Nowadays, when you have people sending applications, you're literally trying to call HR that when are we stopping? Because there's so many applications that come in. So it's all about putting something catchy in the interview. And your number 2 question, Chisom, was saying something about, can you contact the person? So if you look at the NHS jobs, you would see that usually at the bottom there will be 1 or 2 people that you can call. Most jobs will say, oh, you can call Dr. Balosega, you can call Dr. This, you know, try and call them or email them. They don't necessarily have to be part of the interview panel. It depends on what type of job it is. If it's a trust grade job, then it means that that job is, everything is literally handled by the department. It's just the head of department who's like, we need 1 or 2 people in this post. If it's something more senior, then that requires a lot more organization. So you're getting a lot of people from HR, people from management. But most jobs at the SHO level are pretty much just 1 or 2 people who are like, for the next 6 months, we need a doctor in this department. And that's really what it is. So the decision lies with 1 or 2 people. In some rare instances, or maybe not as rare, but in some cases, and especially for some more senior jobs, when they say essential and desirable criteria, it usually means that they have 1 or 2 people in mind. And those desirable criteria are things that preferably those 1 or 2 people that they have in mind have. And the job, you know, they're really trying to get those people. But they're leaving the allowance that if someone comes and totally blows them out, then they might appoint that person instead. What are the things the junior doctors should focus on or do to increase their chances of getting a job? So that's really what all 3 of us have said from the presentation, and I would advise that you try and watch the video if you can. So it's all about getting your CV written appropriately, making sure that you show things in your CV that sell you as someone who is an ambassador of the GMC's good medical practice. You're willing to learn, you are a safe doctor, and you're willing to go through, you know, your CPD on a regular basis. Many people are, you know, the NHS at the end of the day, a lot of it is service, and then there's training. But many of the jobs, particularly at junior level, everybody knows that for as long as you're a safe doctor and you're willing to learn, you would function anywhere, regardless of, you know, your skill sets, if it's at a junior level. So if you can show those things that myself, you know, Dr. Balogun, Dr. Ejiro have spoken about, it should improve your chances. Record yourself and listen to it over and over, particularly the first question of tell me about yourself or tell me about your CV. And the last question from Chisom, number 4, says, what if you do have a question for the trust after the interview? Is it okay to ask? That's a bit of a tough one. You could send your questions to HR, but most times, once the interview is done, the interview is done. And then you just have to be patient and wait for the results. And many people, even if you do not get a job, you should always leave a good impression, because many people, the first, second, even third person might not be appointed for different reasons. You know, there's a lot of like moving around. Some people apply for a job, but they've got another job lined up. And sometimes a lot of the jobs are funding related. So many times when you put out a job, you're actually waiting for HR to say, how much money have we got for so number of doctors? And sometimes your managers can actually call you and say, well, we've got money for 2 doctors rather than 1 doctor. So leave a good impression, leave the contact line open, because even if they tell you, oh, you came second, there's a good chance that, you know, 1-2 weeks down the line, they might call you and say, you know, Dr. Chisom, you weren't appointed last week, but are you free? We want to appoint you now. And that usually happens. Yeah, thank you.
Awesome. The next person is Usmara Hussein. Thank you for your. My question is, what if you're being interviewed for a post that you don't have much experience in? How can we answer the question of why do you think you are the best fit for this role in this scenario?
Oh, that's a very easy question, Usmara. So many things medicine, and that's why I showed you the CanMeds framework. Many things medicine, you know, the truth is, well, I shouldn't say this. This might be taken to well, interpret it depending on how you're going to interpret it. But anybody can really be a doctor, you know, for as long as you train them well. And that's kind of what you need to show. You need to build on your past experience and show that skills from your past experience, you can translate them into being a safe doctor here. And Baloni, you know, Dr. Balogun said something very important about you taking initiative, and you could actually put it to them. You could even draft up. I know someone, and this was at consultant level, I know someone who did not have the subspecialty expertise for a particular job, but he had worked in that department years ago. And he actually said, I'm able to do this. He reeled out his skill sets, but he said, I know particularly for this job, the desirable criterion, I do not have it. But can you give me some months to go and, I've got this plan where I'm going to this other hospital, I'm going to work with them for a while, get those skills, and then I will be ready. Now, this guy, they actually appointed him over some people who had those skill sets. Now, this is at consultant level. What am I saying? You can propose a plan. You could either, even when you visit the department, you could already say, oh, I had met your senior registrars, this. I plan that in my first 3 weeks, I will shadow this person. I will be involved with the on-call registrar. I will do this. I've outlined a few courses which I know would improve my skill sets. And I plan to, I've already booked myself for the MRCS exam. I've booked myself for this course. I've booked myself for this course. I have worked in this. I'm a good team worker. So you sell the soft skills that you've got from other jobs, but now you go a step further by being proactive and showing what you would do to make sure that you're functioning at par with the other people who are already in the department. And if you propose those plans, people will look at you and be impressed and say, yeah, why not? Let's appoint this impressive candidate because he or she is ready to take on the role.
Thank you so much. I appreciate that. So for the next question, so that we don't keep you on the hot seat, I will throw it to Ejiro so that, you come back and everything. I think that sounds like a good plan. So yeah, Ejiro, gets ready. Next question. Okay, yes, he's there. He's not good anywhere. It's from Rajan, who says, I have interview for FY2 in general surgery, junior clinical fellow in intensive care medicine. What are the common clinical scenarios that are asked in both specialties?
All right. So the question, I would not be able to give you common clinical scenarios. However, now take note that it's a junior, you're going for an SHO job. Is that correct? A job for FY2 job. FY2. Now, nobody's wanting you to be a surgeon at that point in time. What they want, usually when you work as a junior level, I think I've done that, work as a junior level in surgery is your main things you do basically would be clerking patients, doing workup for surgery, and also post-operative care. What they're going to be looking at is, do you recognize, for instance, when a patient is deteriorating? And if you recognize it, how are you going to escalate? What sort of resuscitation will you institute, and who would you contact, and how safe would you be in handling these patients? So those are the things that you want to look at. So those jobs, I won't go down to looking at specific jobs for an intensivist, or someone that is a specialist in that particular area. It's an FY2 job. It is taken that you have only 1 year experience in the NHS, and this is your second job. So nobody's said it's very solid information. Main thing is emergencies. If a patient is bleeding, what do you do? If a patient has this, what do you do? And so these are the things I would expect at that level that you'll be looking at. And how would you manage? How would you manage those things? How would you escalate? So those are the things to look at. But don't trouble yourself with specifics, because you can't follow up the questions that will come up with those specifics. I need years of experience to actually be able to answer those questions competently.
Thank you very much, Ejiro. Before we go to the next question, Dr. Victoria, who happens to be my wife, she's posted a link of audit video. I think someone talked about the audit also. Audit video on our YouTube channel, so you can all have a look into that as well. That will give you a guide into so she said you could learn the principles of it, that's about the audits, and still apply. See the link shared above. It is also very possible to do a quick audit in a short period of time. So yeah, that is so. Still from Chisom, I'll leave that with you, Ejiro. Most of the NHS jobs for junior doctors are in surgery, medicine, or emergency. If your recent clinical experience is mostly in specialties such as ophthalmology and co, what can you do and what's your chances of getting a job?
Okay, so I think I've those people that are in those specialties, that's a bit tricky. So I've interacted with people that have done radiology, people that have done ophthalmology, and sometimes you find yourself in a hard pressed to see how you can actually transfer your skills to other jobs. Now, what I would say is there are two options here. If for those that have done ophthalmology and radiology, one option will be actually apply for those specific kind of jobs. Now, the easiest way to do that, what I will always advocate, is get a mentor, get someone who has actually applied for those jobs, and they can actually they can put you through. Now, in the NHS, there's something called taster weeks that people do. You can actually approach a department, a consultant, and say, "Oh, I'm interested in working in this specialty. Is it possible for me to actually have a week or two with you guys to actually understand how this department runs," or things like that. Now, that's actually good. It's good in your CV because what it does, it shows interest. So applying for the job specifically. So if it's radiology, you need to update your CV to actually make you more suited for those jobs. Now, those jobs, take note, they're not the easiest jobs to get, but they are present. Many trusts actually have them. It takes you just searching and meeting the right people to get those jobs. Now, the other thing you can do if you are not getting jobs in that line is to apply for general jobs. Medicine is universal, at least up to a certain level. It is universal. So when you've got if for instance you have worked in ophthalmology, there's nothing that stops you from applying for something like in emergency medicine or even a surgical job, because the skills that you have at a junior level, because the skills that you have are actually transferable. So that's one way to look at it. One thing I tend to say is that anything that will make your CV or anything that will indicate that you are showing interest or enthusiasm about the specialty you're applying for would actually be an added advantage. So things like, say you have done an e-learning on something, you have gone for a course, include that in your CV. So, and that would help you when it comes to applying. Your CV also is very important, because one thing I noticed is when you apply, for instance, a job in emergency medicine, and your CV is not adapted to show that you've got an emergency component, emergency experience, it becomes difficult for the interviewer to place you as being a good fit for that job. But it's very possible. Like I said, those are two possible avenues you can explore.
Thank you very much, Ejiro. The next question I'll move to share, and is actually from Shalika. So the next question is for Share. It says, I'm looking for a job related to pediatrics and neonatology, but the opportunities are very less, and the application I applied is getting rejected. I have 13 years of experience as a SHO in these specialties. I can't believe my application's rejected. I really lost my interest and feel depressed. What is the solution for this? You help him out?
Okay, Shalika, I would say please do not get depressed. Okay, it's not you're going to get a job. So compared to acute medicine and surgical postings, pediatrics and neonatology are not that much. But I can tell you, I go through these jobs every week. I get alerts from NHS jobs and track jobs. And I can tell you that last week when I did one of these, I still saw neonatology. There might be a lot of people applying for the same job. So you need to make sure that you are targeting the PEDS job and neonatology with the essential and desirable requirements like Felicia mentioned. So anything you're talking about in the past, I always say to people who I take for practice, you need to say, I haven't done this in the past. I can do this in your trust. So if you're talking about your house job level, you need to then emphasize a lot about the pediatric and neonatology you did in your PEDS posting. When you get to your surgical rotation, you need to emphasize about PEDS surgery. When you get to medicine, you can generally talk about other things, You get to your obstetric and gynecology, find something related to peds, and also put yourself in the higher level by doing ped specific courses. In that wise, if there are 65 people for 2 jobs, you might be one of the 10 to be interviewed, and then you stand a better chance. Having said that, also, in the whole world, medicine is also about networking. Ejiro mentioned that if you get yourself a mentor would just say one word to another colleague to say, oh, she's great. She's been with me for over a year. I trust her. She'll do well. And that changed the ball game. Sometimes it's just your referees. Oh, I know this guy. He was my boss 10 years ago. I'll give him a call and I would ask about this candidate. And then they just put in a word to say, oh, she's fantastic. Boom, you got a job. So at interview level, everybody can do the job. It's now showmanship on that day. Decide who gets the job. So what I'm saying is, get your CV right for the job, target what they're looking for, and find where you can insert it in your CV, apply smartly, be shortlisted for the interview, and on that interview, give it everything like Felicia said. And find a mentor if you can, and just create a rapport, and you're certainly going to get the job. I wish you the best.
Thank you.
Can I add something quickly, Balosega? Yeah. Just piggybacking on what the last 2 speakers have said. They've said something very important. Pediatrics and ophthalmology are not jobs. How will I say it now? Most people wouldn't go for those jobs unless if you want to build a career in them. Okay, that's one thing you have to realize. So there are actually jobs in those specialties. Now, the first thing is you might have to change the settings of your NHS jobs and maybe even look to the remote areas. And nothing says that you shouldn't start off, you can go way out of London for the first 6 months. By the time you get 6 months NHS experience, that's leverage, and then you can use it to move somewhere else. But one of the things I did, and I will tell you, 2005, when it was really rough to get a job in the NHS, I actually wrote over like 100 letters to different consultants, neurosurgery, neurology, to get my foot in the door. You can actually write specific emails. So if you get emails of a consultant in like pediatrics, neonatology, off my head now, I can remember talking to, I think it was in Stoke. There's a colleague in pediatrics, and I know they needed, they were short-staffed. So you can write specifically to units. And, Ejiro said something very important about even taster. You could start off, or you could shadow. The first couple of weeks, you could just observe things. And then, once they see what you've done, they will be like, yeah, come and work with us. So that's another way of doing it in terms of writing specific emails to head of departments and just outline. You can, get your CV all well done up, attach it to the email, and just say, you need some mentoring, or you want to build a career in this, and you're wondering if you could come and work with them for some time. That's what happens, because usually if you look at the F2 rotations, jobs like pediatrics, neonatology, and ophthalmology, they never really add them to foundation rotations, because most people don't want to go there unless if you want to build a career there. So those departments or those specialties would always have a deficit. And then you just have to strategically position yourself into getting a job in those units by specifically going after the power brokers in those units.
Thank you very much, Andrew. Appreciate that. Still on share, before I moved away from you, there's a question from Namdi Peter. It says, if you are asked if you have done a procedure you haven't, is it safe to say you haven't?
Thank you very much for that question. I remember my first job in the UK. I was coming from Nigeria, worked in UCH Anaesthetist, I've probably seen maybe 2 central lines. And boom, online, the guy asked me, can you do a central line? And I said to him, I understand how to do a central line. I haven't done much, but I'm a very fast learner. If you teach me, I will deliver. I got the job. So you need to be honest and show that you will learn. If we know everything, we won't be in training. We won't, even as consultants, you're still learning. So be honest and say, yes, I don't know it. I understand the basis of it. I understand the indication, contraindication, complications of this, and I'm a very fast learner. You teach me, I will reproduce it safely. That's it.
Thank you very much for that quick answer. So I move to you again, Andrew, and question from Tega, Ejiro Tega. It says, as regards the work experience, does the hospital capacity and the weekly patient turnover affect chances of employment? For example, a hospital with a 16-bed space.
Well, you know, as everything in the NHS is all about a balance. Consultants get regularly called about balancing teaching versus service. So in a way, the bed space will probably influence the amount of doctors that you need. Everybody, and that's why the way, if you look at hospitals, some hospitals are foundation trusts, yeah, and there's that everybody's doing their own business on their own. There's a level of autonomy. So every hospital wants to tick certain boxes. Every hospital wants to reduce their waiting list. They want to get patients in and out, and they need doctors for that. So in a way, the hospital capacity and turnover would influence the chances of employment. But saying that, a lot of things might not necessarily be just on turnover. Some hospitals are predominantly outpatients, and you would need doctors to manage that. Some hospitals are predominantly like A&E, and you need doctors to manage that. So sometimes it also varies on the specialty. But most trusts, all they're doing is trying to tick those boxes, and they will just say, oh, we're allocating this money for this because we need 20 doctors to be able to do this job. Now, most hospitals also would have training spaces, and based on the arrangement with the deanery, you might have like 30% of your doctors at any point in time should be working with the deanery and have to be trained. So the amount of people that need to go through training also impacts on the amount of jobs that people have on offer. So there are a lot of factors that go into it, but I wouldn't bother myself with that, because yours is just, you need a job, unless if you're into something, top tier like management or something. I hope that answers your question, Tega.
I believe it should get to a very large extent. Thank you very much for saying that. I'll go to Ejiro. Hold on. Sorry, one more question for you, Andrew. Sorry. And it's from Shalika. Yeah. If the essential criteria mentioned that you work right in UK essentials, can't we apply? Sorry, I'll take it again. If the essential criteria mention that you work right in UK essential, can't we apply for those posts? Because I have only a visitor visa for 6 months and it is going to expire soon. Please advise on this, sir. Sorry, yeah.
Yeah, that's a tricky one, because I know people who and now if you go on the GMC website and you check GMC sponsors, there are actually now a lot of trusts that are now beginning to sponsor people. So sometimes I actually know a few people who've applied now, who they would apply directly, and their CV gets sent to the Royal College. It gets reviewed to see whether the hospital can sponsor them. So there are lots of avenues where hospitals sponsor. Bapio actually has something set up. I know Mansag is trying to work on something with the GMC as well, where the bodies are also trying to be, they're trying to get the power to be able to also get sponsored, people, individuals sponsored, because Bapio has done that. And if you check the list of GMC sponsors, there are different avenues. So you could either go into your Royal College, like obstetrics and gynecology have got a very, very well and tested system where they apply directly to the Royal College and they get them in. They get the visa sponsored. A couple of trusts have that as well. I know some trusts just on the back of my head that have that. So try and find out what specialty you've got. Maybe contact your Royal College as well as the hospital, because the Royal College might be able to liaise with the hospital and get you sponsored. All they need to do is just review your CV and find out. Some of these people, you don't even need to do PLAB as long as you get the go ahead. So there's so many avenues these days, and it's all about asking the right people. But you can talk to HR. I know someone who sent an email to HR, and it was HR that connected her with the appropriate Royal College. So there are all of these ways, you know, you don't necessarily have to put down by the your work rights in the UK. But saying that, there's certain applications on NHS jobs where there will be tick boxes, and some of these jobs might have specific criteria where they're saying if you don't have the right to work in the UK, you won't be able to go on to the next step. So there's some like that, and you might do well to just avoid those ones for now and just contact the HR directly and see what the options are.
Thank you very much for that. Good one, good one. I'll move on. Before I go on, Dr. Victoria's posted a link. So when we do this education series, we usually post a link to improve our educational series by filling the survey. So that's a link to the survey. If you go to the chat box, chat area, just click on it. Takes you to a page where you fill the form for us. So please do that, and it will help us a great deal. The next question, I normally want to take it to Ejiro, but this person at Ejiro is actually throwing this question to Share. So Share, get ready. It says, would you please share your journey with us? I'm interested in residency in anesthesia, critical care, and I've been trying to get an observership role in that department in the Leeds Trust and York Scarborough Trust, but no success yet. I have been advised to do an observership in emergency medicine or surgery instead. I would like to hear about your path after passing PLAB 2, please. What's your advice, Share?
Oh, hello, fellow gasman. So basically, nothing good comes easy. That's what I would say. I finished from Mayflower School, and I remember in Mayflower School, they used to tell us that may your road be rough. So that was a prayer in Mayflower. Not. So my journey, I'll tell you first. I arrived UK 2013. My arrival in UK was linked with Felicia here. We've been friends since 100 level in university. I was already in training, and at that point, towards the end of my training, I was getting really bit, kind of like, oh, things are not going well. I'm not happy with what I can do better than this. So I remember that night I texted Felicia and said, man, I want to leave this country. And he said, now you've made up your mind. So he was a neurosurgery training, spoke to the anaesthetist, and the anaesthetist said, oh, tell your friend to send me the CV. And then I sent the CV. Felicia will remember the friend of his that he linked me up. And that guy was God sent. That guy was even saying it to me, with this your CV, should we write to your hospital that you want to resign? I was like, calm down, we will take things easy. So I arrived UK 2013. The job I first started, fantastic job, good hospital, was a role of specialty doctor. Specialty doctor is like you're working in between the trainee and the consultant. You need a lot of experience to be there. When trouble comes, you have to be ready to kind of lead. After doing the job for a year or two, my mentality changed because I tell people our pathways, our goals change at different times. You arrive this country, you want to make money. After a while, just like I made the money, then I want to just get to the top of my career. So I realized that getting to the top of my career required me being more. So I said to myself, I want to be a consultant. To be a consultant, I needed to resign that post and join the training because you cannot go so far if you have not gone through the training. They'll easily say, oh, he's not part of us because he did not go through the training. So I dropped the good job, the good salary, I dropped my pay, I went back to the exams. The exams are not easy, but they are doable. They're passable. So I went there because the exams in Nigeria are not equivalent. So I have to do it. Immediately passed the exams, passed that, I applied into training. I changed my hospitals also because the hospital I was at that point in time was not very supportive. I needed a hospital that is going to sign whatever needed to be signed. So I changed hospital. The other one was very helpful, the second one. I got into training. Once you get into training, you just need to go to the hospital and do what you're told. You don't need extra workload because the deanery makes sure what you need to be trained with, what you need to people to teach you, they're already there. So once I got into training, things just became a pathway. They told me, on this day, you will become a consultant, and that's it. And I just finished the training, became a consultant. Now, anesthesia, people will tell you, you cannot get into training. Just tell them that you know somebody who's been into training, and I'm one of them. So it's doable. For your observership, let's see what we can work out together. I'm not promising anything, but I can speak to a couple of people to say, I have a friend. Send an email to balosega@yahoo.com and let me see what I can do for you as a fellow gasman. Thank you.
Thank you very much. Still on observership, there is a question from Rajan, and he says, how much is the advantage of doing observership during interviews to secure a job?
I'll be very honest. It doesn't change the ball game. It doesn't. It might help you into knowing people, and these people will say, oh, and there's a job coming out next week. That's the advantage. You're basically observing. You cannot touch a patient. You cannot fill a form. You're walking on the ward round. You're appreciating the doctors. You feel like a doctor. You're not a doctor. When you get to interview, you can actually use the knowledge like, okay, they've mentioned duty of candor. Okay, I've read it all. Otherwise, it won't make you score a very big mark. The other presenters may have a different opinion.
All right, thank you so much. Move to Ejiro, and first is from Lillian. I have practiced general medicine, all specialties, for over 6 years, and now I work in A&E for 2.5 years now. Will you advise me to take on middle grade jobs in emergency medicine, even though I haven't done residency in it?
Okay, let me just, I think, answer the last question that Shayed talked about. So observership, I did observership myself. I did observership for 2 months because I didn't really have anything to do. Observership does not count as clinical experience because the guideline for observership is you do not touch patients, you just see. You make no decisions whatsoever. So even when you do observership, it doesn't matter. The only thing, like Shaya said, it brings you in contact with people. And if, for instance, there's a job opening, they know you, then to an extent, then probably you get first dibs at the job. But even if you don't have the requisite clinical experience, they will not necessarily take you. But I wouldn't. It's if you can get something else, a substantive job rather than observership, I think is better. For Lillian's question, I think you are more than right for a role as middle grade. Now, but you see, the main thing here is it depends on how confident you are. In my personal experience, I worked my first job in the in the NHS was as an SHO in emergency medicine. I did that for 6 months. And after then, I went into a middle grade job, which was from there I went into GP training. So long as you don't necessarily need to have done training to get into a middle grade job, 2.5 years is more than enough experience. You've seen it all. You literally seen it all. You may not have managed things directly, but you've seen your seniors actually manage them. And all you need to do is, as safe as you have seen them do, you can apply for those jobs. And I'm sure that anybody has worked with you, seeing the 2.5 years of experience will more than likely take you for the job. However, I'll say this: rather than moving from one non-training job to another training job, this is just my personal opinion. It always gives you the best advantage if you go into training. So if emergency medicine is what you want, by all means do. If it's general medicine, do. But going around in the non-training circle, for some people it serves a purpose, but ultimately deprives you of a lot of things. It makes your journey harder in the NHS, so to speak.
Thank you very much for that. And next is Chioma is back again, and Chioma says, are the responsibilities of FY2 doctors high, and what are your thoughts on starting from FY1 position, just to be sure you have gained enough NHS experience before confidentially moving to a higher position? Still on Ejiro. Yeah.
Okay, so responsibility of FY2 doctors is just like a house officer, to be honest. A house officer in first year, house officer in second year. Personally, FY2, some trusts will advertise as FY2, others will advertise as SHO. The jobs are the same. There's nothing that's higher than the other. The point really is that you are managing patients, you are being overseen by registrar and consultants, and in terms of basic management of patients, seeing patients, clocking patients, that's what you essentially do: chase blood test results and do investigation. But I wouldn't. If that's the job you want to apply for, that's fine. But when you look at an FY1 job, no, I wouldn't advise anyone to go for an FY1 job. One, the reason why I wouldn't advise that is UK trained graduates, that's the first job they apply for. So you can imagine that the competition for such jobs is very, very high. Why put yourself through that? If you have done house job wherever you are coming from, for you, at least for anybody to get a GMC registration, you've done your house job. That's your FY1 done. Just apply straight for FY2 SHO, depends on how much experience you have clinically, and yeah, should be fine.
Good. The next question is actually for you, Ejiro. It's from Okpe, and it says, I'd like to please ask about GP training. Do you think it's a good idea for a person to start GP training without previous NHS experience? Also, what areas are advisable to choose to secure a job after MSRA results? Thank you.
First answer to your question, do I think it's advisable? And my answer will remain no every single time. The reason is this: it's not that people don't do this. People actually, I know people right now. I know somebody, in fact, somebody from Saudi Arabia. She's a doctor, and they got jobs directly. But it's a harder part to take, because when you actually get into GP training, the assumption is that you are starting at the level of someone who has at least 2 years of NHS experience. So when you do GP training without any previous NHS experience, you are battling two things. One, you have to prove, you're trying to get the NHS experience, that's one. Then put on top of that the pressure of training and the requirements that are needed. I just feel, for those I've interacted with, although, for instance, in the UK, there's a group that supports people like that, but I still feel it's a harder part to take. That's one way. That's one reason I would say just do a non-training job first of all, get a bit of experience. Even if it is 6 months, it does a lot for you before you move into training, any sort of training. In terms of what areas are advisable to choose or secure a job of after that. Now, areas that are advisable, I would usually say if you want to pick an area, any area in the UK, as far as I'm concerned, is good for training. London, an exception, just because London is very expensive to live in, and your small salary from training will be far a lot of pressure on that salary. However, anywhere else. Now, one thing you can look at is this competition ratios, and also number of spaces available. If you look at number of spaces available, I had this conversation too to somebody. I'd rather choose a place that has 50 spaces available for training than a place that has, or rank a place that has 50 spaces available for training first than a place that has 2 spaces available for training. The problem with that is that with 50 spaces, you know that the competition ratio is less, the pressure on space is less, but with 2, it is more. But one other thing you can do after your MSRA is rank everything. Rank every single space, so that no matter how you fall, if you don't get your first choice, you get your second choice, at least you have the chance of getting a space. It's still a chance rather than just rank a few areas and just hope for the best.
Good, thank you so very much, Ejiro. Back to Andrew. Chinwe has a question with regards to audits done. Are we asked to present an evidence of audits during audits done during interview? Sorry.
Now, I must say that from all the interviews I've been part of, only once have I seen a fellow interviewer ask a doctor for evidence of audits. Most people don't get the formal evidence, but saying that, if you find that any trust that you work in, when you do an audit, ideally you're supposed to register your audit with the education department. Once you've done the audit, then you get a certificate. So I usually get that for my SHOs and registrars, but most people don't. But at the interview, people will ask you to talk about the audit. So it's usually talking to, because many times there are a lot of things we've done in, let's say you're coming from Nigeria, for example, that we've done in Nigeria that are actually like audits, but we're not calling them audits. And the truth is, you won't really have paper proof or certificate proof of those projects. We'll be able to talk about it, be able to talk about basic things like the quality improvement, what you wanted to improve, your sample size, what it was all about. Just be able to talk about it. That's usually enough for that question. So most people won't ask you for the evidence, but you know, it's very easy when you've interviewed quite a lot of people. Someone said earlier, I think it was either Balogun or Ejiro, it's very easy to say when someone is bluffing. So just be careful, because if you are suspected for just bullshitting your way through, then that will get you in more trouble. So when some numbers are not adding up, you'll be like, man, this one, we're not appointing him. So just be careful. Don't talk about something you've not done. Ejiro said something about when GP training, when you're doing preferences. Sometimes it's also good to look for resource limited areas. So for a couple of years, places in like Hull, Boston were doing these extra projects where they were actually giving, I don't know what the term is, I've forgotten it now, but they were giving trainees, I think 20.
They call them TES areas.
Yes, TES areas. Yeah. So if you look for places like that, that seems to help a lot, and that's the incentive, because they had to have meetings and get it passed through, where because they were like, doctors were not coming there, and this is for all specialties, including mine. A lot of doctors, you know, they would advertise jobs, people would not go for jobs in those areas. So they now had to add the extra incentive of giving you extra money. And if you rank those places higher, then it's most certain that you would get a job as well, or your chances are better.
Awesome. Thank you for that. Before the next question, just to let us know that if you have any queries, questions afterwards, you can send us an email. It is on the chat area, balosega@yahoo.com. Very easy, balosega@yahoo.com. Whatever inquiries you want to make, or anything, questions you have, just let us know. Still on Andrew, next question is from Azizat. Can I write the MRSA exam before getting a job in UK?
Yes, the MRSA exam is something that is new, and the reason why this is coming up is this is actually a response to the numbers. There's so many people now applying, and it's so difficult to organize interviews for everybody. So they're using this MRSA exam to You're saying MRSA. That's what you wrote, right? Because it's MSRA. I'm just like, so that I don't mix it up with the bug.
Oh, okay, sorry.
Yeah. So it's really
MSRA,
to screen out everybody. So yeah, and you know, increasingly, just like PLAB, if you go online now, there are now many places that have started doing MSRA practice as well. So within the last 3 months, all of a sudden, there's so many organizations now setting up these exams and practice. So that's another thing to start considering. Yeah. So yeah, get to do it. It's preparatory for everything. Even neurosurgery, it's now part of the requirements. Same for GP and same for, I think just recently, this week, I know I saw a mentee of mine who was really annoyed because I think it was Thursday or Friday, because now they've added it as a requirement for core surgical training. So it's going to be used for everybody. So yeah, get on board with it.
Awesome. Still one more question for you before I move to the next person. Shalika is back again. Most people are suggesting to apply for training jobs as the first job rather than applying non-training jobs. If I have 13 years experience as a SHO, what is the ideal job to start with?
This one, I think this one is very straightforward. You have to know, I think GP is the one specialty where people can probably get training jobs without having worked in the country. And that's not, it's not like that would be the case for everybody, but I think that's at least, you know, that can happen. Jobs like maybe anesthesia and, you know, Baloni is there. Neurosurgery, definitely there's no way you will get a job from outside the country, you know, like a training job without having worked in the NHS. And I don't think pediatrics as well. So know about your specialties. It's always good to know about specialties. Specialties like ophthalmology, there's no way you can get a training job from outside the country. So many of these jobs, to break, you know, kind of get your leg through the door, you will probably have to start with non-training jobs. In fact, I even know people in some specialties who had finished training in their countries, you know, India, Nigeria, East Europe. They'd finished training, but they had to work as SHOs first in certain departments, at least do 3 months or 6 months, just to get used to the NHS culture. And then once they've worked with people, people would now upgrade them to the appropriate level. So not every specialty has that option. And if you see that your specialty does not have that option, then it's better to have that timing. And I like what Baloni said. You know, he said your expectations and what you want changes with time. There's an evolution, and you know, you have to have that plan. You know, so if you start off and say, well, if I do a non-training job, find out. Many times when you get a job, always find out what the escape clause is. What is the notice period? How many months before? Do I need to give it 1 month before or 3 months before? Because if you do something where you start off, or even if you go for an interview and you get a job, and then you now suddenly say, I'm not taking the job, it can actually affect you in the next job. You might not realize it, but sometimes people actually, so I know someone, and I say this, I know someone who went for an interview, got the job, and then 2 days later said, well, I've got another job, so I'm not going for that job. Now, the people who interviewed him were so slighted by that, you know, turn down, that they actually contacted where he was going to start his next job. So they actually sent an email to say, you know, bad ethics, poor probity, and they literally set things up on a bad template for him over there. So be careful about how you play units against each other. If you look at the laws, it's always better if let's say you're going for a training job over a non-training job, then you have a leg to stand on. But if the jobs are of similar standing and similar training opportunities, similar labels, then you don't really have a leg to stand on. So be very careful how you make those decisions as well.
Thank you very much. Move to Baloni right now. Quick one, 2 questions. Is it from John? Is it advisable to start from a private organization rather than NHS?
So I'm always the unlucky person who gets asked this question the last educational call.
Every time.
Also, same question to me. And I'll be honest this time around. The last time I said no comment. This time around, I will give a comment. I won't advise anyone close to me to do that, because you're going to a private. The mission of the private is to make profits. They don't care about developing you. NHS will develop you. In NHS, you can lay your plans on the table and say, sir, in the next 1 year, I want to see myself in a bigger hospital. In the next 2 years, I want to be in training. And he will say, okay, that's a good one. We will support you. In private, they just want you to come, do the job, go back home. Any extra thing that takes money off them, they're not happy with it. Once you mess up in the private, they'll kick you out. Before you know what, they say your visa has been, we've kind of sent a message to not all of them, but they won't support you when the chips are down. I know a particular person who worked for a particular private hospital, went to NHS hospital, as in he was employed by the private, but the private now sent him 1 week on, 1 week off to NHS hospital. And it was just a text from a nurse against him that if he was NHS staff, they'll sit down and just say, doctor, this is how we do things. You're going to go for this course and you're going to come back and do better. Before anything, they just stopped him from coming to the NHS hospital while they're investigating, and he's not getting paid. He's really stuck at that point in time. And in addition to what Felicia said earlier, if you go to an NHS and you start talking things you have not done, they will report you to GMC. I know 2 doctors who have actually said they did a research, and somebody on that trust said, I know about this research. I don't think this guy was there. And after then, they looked at it and they just agreed, forward him to GMC, and that's a probity issue. That's it about that for now.
Awesome. Another one for you before you go.
Can I say something about?
Oh yeah, go ahead. Go ahead.
So working with private hospitals, incidentally, my first job in the UK was a private hospital for 2 years. Now, why I did that was that, first of all, that was the earliest job I got, and it fit my purpose because I think at some point I chased USMLE to a very large extent. Now, there's a problem with working with private hospitals as your first job. Apart from money, it goes beyond money. The main thing is you do not get support. That's the biggest problem. When you work in a private hospital, the job you do, anybody that has half a brain can do the job. Your job is prescribe paracetamol, prescribe ibuprofen, prescribe cocodamol, insert catheter, take blood. That's all. Then dispense medication. Sometimes, this is my personal experience, I feel sometimes it's demeaning. You're not learning medicine. What actually saved me in those 2 years was that after 1 year, I stepped out and started doing locums in the NHS, and that's what changed my experience all through. Now, that being said, for some people, that's just the only job they will get as their first job. If that's the only job that you get, you've applied so many jobs and you are pressed for time, fine, you go for it, but you must have an exit plan. That cannot be your permanent job. It gives you a foot in the door. You have a COS, you come in. Yeah, but the problem, what I find, the pattern, and Balo knows about this, they can be very exploitative, very, very exploitative. And they would throw you under the bus in the drop of a hat. They'll throw you under the bus. They don't care. It's not, everybody does not have that experience, but we have had a lot of bad experiences from people come to us, and that is just one thing to be mindful about. You're not going to grow clinically. You're not going to learn anything. Consultants are not interested in you at all. Make sure my patient does not die. That is the that's the rule. Just make sure my patient does not die. Any other thing is your business.
Thank you very much, Ejiro, for that chip in. Still on share from Okwe. If I do get a job offer from sorry, if I do get a job offer after MSRA, can it be deferred, and for how long?
Okay, so when you get a job offer and you want to defer it, the question is the reason for the deferment of the post. They would have usually asked such a question before the interview. They would have said, is there any reason, I remember filling my form for training, is there any reason you may not be able to start on this day if appointed? If I had said to them that, oh, there's no problem, if you give me the job, I will start on August 8th. And then after the interview, May, June, something new happens, then that is, say, oh, I have to take care of my kids because someone is not feeling fine in my family. That is acceptable. You cannot then come to them to say, oh, suddenly you are 9 months pregnant. They'll say, oh, 9 months. But that 9 months, you must have been maybe 5 months pregnant when you were filling the form. So the thing about it is, even though they may accept to say, okay, let's just panic, then let's just take it, but that's not the right thing to do. There is always a link between the hospitals and the training and the consultants. I can tell you for a fact, the hospital I worked for last wanted to employ me as a consultant. But, you know, you want to have a lot of options when it comes on ground, because you're going to consider your wife and your children and the schools around and what my wife would do. So I was also going for interviews, but then you keep it low. They are fixing theirs for October. There's a job coming up in September. You've applied, they want you. But you know what happened? Just before I go for interview, my supervisor will call me and say, all the best in your interview tomorrow. So she knew everything. So at that point in time, just like, okay, I just want to go there. Let's see, options open. So I could now say, okay, these people, they know themselves. So there's no point messing up with them. Just be honest and say, I'm looking for the best option. The offer of this hospital is high on the list. But then when I turned them down, I just said, for family reasons, I would really like to go. They weren't happy, but it's my family, it's my job, it's a permanent one, I need to go. And then I left. But you cannot live on a bad note. You have to be open. And having said that, I would also mention that Balogun is not just an accommodation provider or providing company. We do CV reviews, and a lot of our guests have benefited from it. I know personally, I sent my CV to Felicia, and Felicia did a lot of job trying to say, my guy, take this off, add this to it. These are the things because you have not worked in the UK system, you don't know what to actually put in, and we shortchange ourselves a lot. So if you send your CV to us, we'll look at it and say, oh, you can add this. These are the jobs you can go for, and these are the job specifications. Add this into O&G, add this into this. Sometimes we post weekly jobs on NHS job and track jobs, and we post it on our Instagram page. And you can always go to our Instagram page, it's Balogun, and you will see a lot of jobs as they come. And we look through the very good ones and we just post them. We try to balance it, surgical versus medical, so that one specialty is not dominating. And sometimes pediatrics, when they come up, the rare ones, we just add them into it. Interview practices, I remember, I can mention a lot of people who have given us good feedbacks and reviews because they got a job by contacting us and also going through the practices regularly. Some people, we just tell them, you're not doing very well. You still have to come back again. Let's do it again after 1 week. Go and do this, talk to the mirror and come back. We write letter to embassy, which is acknowledged, and that may just be what you need to say, this is where I'm going to be, embassy, somebody will take care of me, there's our address and whatever. We write a letter of embassy to the embassy, and we've done that for almost 2 years now. And we always provide educational courses, and we also look at your feedback, courses you think will be beneficial, and then we add it onto it. Thank you very much. Hello, Bobby.
Sorry, I didn't know I was on mute. I do apologize. Thank you very much. Unfortunately, we can't take it further for now because of time. It's already 2 hours, and lots of questions are still coming in. However, we would like to appeal to everybody whose questions we've not been able to answer right now. I mean, we've not answered your question. Just forward those questions straight to balosega@yahoo.com. It's balosega@yahoo.com. Very easy. On the subject, just put interview questions. And once you send them today, we should be able to answer all of these questions between today and the next 48 hours. Sorry, I'm not going to guarantee that we'll answer everything tonight or tomorrow because there are lots of things we do. Admin will send it to us and everything. So between today and 48 hours, we will do our best to answer all of the questions. I do apologize that we can't take all the questions. We actually didn't know there will be too many questions like this. Not your fault. You're not doing anything wrong, but it was wonderful. So it is great to have this program today. Really, really appreciative of the panelists. Dr. Alalade, you've been wonderful. Your presentation was on point. I thought I was very good in presentation. I need to go and learn more on how to present, honestly, because you were just cool, calm, and collected. Maybe I do shout. It's not my fault. I love that scripture that says, shout to the Lord. It's not my fault. So, so you were very cool, calm, collected, beautiful. Thank you very much. And we really appreciate you. We hope that when we call on you again soon, you will answer us. It might be another global one we'll do very soon. We'll call on you again. Again, Dr. Ejiro, thank you so much. Before we call you, you are always coming to us, so we appreciate you so very much. It's a big, big, big honor, big pleasure to have you here with us. Balo, we're in this together for the chippings and everything. Also, Victoria, Dr. Victoria, my wife, the back end, she controls our admin, and does a lot of good work and everything. So thank you as well. Just like Shaya has said, we do a number of things in Balosega. It's not just the accommodation. One of them is just what we're doing, the education series. We try to do it quarterly, and all that things to do, CV reviews and all those things. Some of them are free, many of them are free. Some of them cost a little token, which it is very, very explanatory and everything. Again, if you have any questions, like if you have asked questions that we did not answer tonight, just forward those questions. Just copy them from the chats and forward them to balosega@yahoo.com. That will be very, very, very expressly answered between tonight and the next 48 hours. So on behalf of Balosega Limited, I want to say thank you. My name is Bobby Sega. People call me Sir Bobby Sega, whichever. Just feel free to call me Sega, Bobby, whichever one. We say a big thank you to all of you that came, attended today's program. For those who came very early and had to wait for about 10-15 minutes, we do apologize for that. Some errors you can't just ignore, so we appreciate you that you waited this long. Thank you very much. Till we meet again, we say thank you and God bless you and bye for now. Thank you very much. Thank you. The panelists can just wait behind for a short while. Thank you very much. Thank you. Thank you. Thank you. Thank you all. Thank you all. Thank you all. Thank you, Lillian. Thank you, Nafisat. Thank you.